Well, I want to welcome everybody to this Zeiss Refractive Symposium. We were going to be talking about optimizing outcomes, satisfaction, and efficiency for refractive surgery patient and the surgeon in clinic. Do want to give a financial disclosure for all those who are joining in. All of us are consultants for Zeiss. We all perform the SMILE procedure along with other laser vision correction procedures. Our panel this evening includes myself from Kansas City, Rex Hamilton from Los Angeles, Eric Liu from Los Angeles area, and Rolanda Toyos from Nashville, Tennessee. So what we're going to talk about tonight is efficiency for surgeons, the efficiency and quality of vision for patients, and techniques and pearls for increasing surgical confidence. And we'll be speaking specifically about the SMILE procedure, which is growing tremendously internationally, or already done that, and is increasing dramatically in the US as well. So a couple of things I think it's worthwhile looking at is looking at where refractive surgery is right now. And I think we've seen some really interesting data that's transpired with the COVID-19 pandemic that I think a lot of us, myself included, would not have guessed was the case. We're going to look at the value proposition, maybe how that's changed during the pandemic. And again, we're also going to look at how the SMILE procedure changes what we do in laser vision correction. And I think amongst us here, we probably, I don't know if we're at 100 years, but I bet we have 75 plus years of refractive surgery experience post-training in the US. So on the slide left, we look at industry trends and consumer indices. This is the Michigan Consumer Sentiment Index, and it's basically been flat for the last several years, although there was this dip associated with the beginning of the pandemic. In the middle in the blue is refractive surgery procedures. We saw definitely a dip going down here during the second quarter of 2020, and this is obviously from COVID, where virtually everybody just absolutely stopped, and then everybody essentially got back up and running sometime in May. And then the consumer price index, which has gone up. So I think it's going to be interesting really for us to talk about what's happened in this region. In fact, I think this dot that's right here, my guess is it's probably higher than that. And we'll see what the other speakers have to say. And now looking at monthly industry trends and consumer indices, as far as refractive surgery procedures, again, this is kind of blowing up what happened over here on the left-hand side, looking for April through September 2020. We obviously see an increase, going 60,000 procedures per month. And over here, you're talking about roughly 60,000 plus procedures when you're doing this on a quarterly basis. So I would love to see where we are in October and toward the end of the year, and kind of what the panelists are thinking in that regard. So the first slide, actually, let's go back one slide, I'm sorry. So one thing I do want to ask the other panelists, and maybe we can start with Erica, what has transpired for you all in Los Angeles since the shutdown and then coming out of the shutdown? If you can compare that maybe from the same time period, let's say May to now, 2020 versus May to now, 2019, what have you all seen in your practice?
So for 2019 to 2018, we were pretty stable. I think some refractive practices went down a little bit. From what I heard, we were a little bit up. And then, of course, LA was one of the earlier kind of hot spots. So we shut down completely. And as we were opening back up, we opened up slowly to make sure that we were kind of complying with all the new rules and just, really seeing how everyone kind of fit in, how the staff felt about everyone's safety. And then since then, it's just been really difficult to meet demand. Just like it looks like in the chart, that's pretty much exactly what we've experienced, where people just want to get the procedure done. And at this point, to maintain social distancing and limiting our clinics, we haven't really been able to meet that demand. So it seems like that is a pattern that we've heard across the industry, but interested in what everyone else is experiencing as well.
Great. Well, thank you. Hey, Rex, if you could chime in, I mean, you and Eric are in the same state and essentially the same county and city. What have you noticed in your practice and what's transpired over the last 6 months or so?
Yeah, well, I'm sort of in a unique situation. I started my own practice after COVID. I had made a decision to to go out on my own in January before all this happened. And so I basically just had no practice during the shutdown and opened right afterwards. And so, we've been sort of ramping up and seeing a really great demand as well. I think something really interesting, I looked at the market scope data, looking at the refractive surgery market for third quarter of this year versus last year. And it's interesting, SMILE now makes up almost 8%, just a little bit less than 10% of all refractive surgery procedures. That represents a 65% increase over last year. A pretty dramatic increase for SMILE. And I think, we're going to see why that is, during this discussion.
Great. Ro, can you tell us what's going on in Nashville? And then if you could maybe start off the conversation of what's pushing people to do refractive surgery now. I'll give some insight from what we see in Kansas City, but if you could share what's transpired for you 2020 versus 2019 and what's pushing people.
So we had a mandatory shutdown just like everybody else. So I think there was kind of some pent up demand when we opened back up for Lasik, the patients that we had to cancel. But this was actually my first summer with SMILE. And what I noticed right away is our numbers increased. And the reason that normally from this year, looking at 2019 and before that, and I think our numbers increased because usually in the summertime here in the South, people are out the lake, they're out on inner tubes, in the water, they're doing all these water sports, and they're doing weddings. So women want to wear their makeup at weddings, and you tell them you can't wear makeup for a while with a regular Lasik case, and everybody wants to be in the water. So usually the summertime we're really slow, but this summer we were ramping up, and we were doing double the amount of numbers because we could offer SMILE and tell people right after surgery they could go ahead and wear makeup and swim and do their normal thing. So we really didn't have that pushing people out. So if people wanted to get the surgery in the summertime, they could get it. So that, to me, that is going to be the biggest difference in our practice, is that we're really not going to see that summer lull.
Gotcha. Anybody have any issues with people coming in saying, my glasses are fogged, or I just simply hate the mask? Has that changed? Or contact lenses I'm sick of? Rex, if you want to jump on that one.
Yeah, I mean, absolutely. I mean, people are just, they're fed up with having to wear that mask. And the other thing that we see, saw a few patients today that said the same thing, is, they're concerned about emergency situations and, social unrest. And, I don't want to have to find my glasses. I don't want to have to put my contact lenses in. I heard that 2 or 3 times just today. So that's also another kind of aspect of this that I think is driving people to seek out refractive surgery these days.
What about, the one thing we have noticed, and when we got back up and running, I really never was saying, gee whiz, we have all this pent up demand, that's why we're busier. At some point you run through that pent up demand and you're still really busy. So we've been, if we compare this time frame of May to now, 2020 versus 2019, we're up 50+%, which is ginormous. And I could not explain it all by mask. Well, that was the first indicator that the coordinators were saying, yeah, people are calling in, they hate the fogging of their glasses. And then I started asking, I was asked patients certain questions. The one thing I clearly did not get was, hey, I'm getting this government check, and so is my wife, and we're getting one every week. I never got that one time. And so it's something else, than that, obviously. And so I attribute it to the mask. I want to do something for myself. We didn't take spring break. We didn't take a summer trip. We've got this extra money sitting around. I'm sure you all have seen this as well. The number of bikes being sold, the number of swimming pools being bought, the amount of plastic surgery, I think, being done. I mentioned earlier the amount of people having, permanent dental work, and then laser vision correction. Those things seem like huge winners to me. I wouldn't want to own a restaurant. I wouldn't want to own a movie theater. All the others I'm good with. And luckily we're in that arena. So
I think with new technology, so we're advertising this as new technology, which it is. And everybody's all, we're in the Zoom age right now, where people are adopting new technologies that they've never adopted before, but they're looking for the new. What's the newest thing? What's the latest thing? And Smile, like Rex was saying, is the latest thing that is growing, and you can offer that, and people, oh yeah, you know, my uncle had LASIK, my dad had LASIK, and this is the way it was done with him. How is it different now? It must have improved over the last 10, 15 years. And we can say, yeah, we have this Smile procedure that it doesn't have a flap like your relative had a flap before.
Yeah, I mean, that's a great, we kind of jumped on that very important thing. And, you know, I mention this to, you know, patients all the time, you know, no flap, no flap, no flap. And you would have to worry about, you know, sound, smell, and so forth with the procedure of pain. So do you all want to talk about, I mean, Erica, Rex, how that's impacted how you talk to patients, the fact no flap, and, you know, if you want to compare that to PRK, LASIK, however you want to spin it, what do you tell patients?
I'll go first. I really love the flip book that Zeiss has. It shows the PRK procedure, the LASIK procedure, and Smile. And so I actually go through that flip book with each patient, kind of showing them, you know, the generations of refractive surgery that we have. And when we get to the Smile, we talk about the fact there's no flap. And I usually say something like, you know, LASIK's a great procedure, and, you know, as a surgeon, I know the flap is really not that big of a deal, but patients are concerned about it. You know, people play basketball, they put on makeup, and they're worried about that flap, and you got nothing to worry about because there is no flap. There's no moving parts. And then I say, and the best part is, it's the easiest procedure to go through as a patient. It's the fastest. There's no pressure on the eye. There's no sound. There's no smell. And the next day, you can do whatever you want. I'm not going to restrict you from anything. So it's just the cleanest, simplest procedure, and the no flap is sort of the jumping off point. But there are a lot of other features that are equally as amazing.
Eric, if you want to give some thoughts there.
Yeah, similar to Rex, obviously the no flap thing, we still talk about LASIK like it's a great procedure, which it is. It's really an amazing procedure, and Smile is just, for certain people, does have those certain advantages. One, the most kind of hesitant thing that most patients are of a refractive procedure is the dryness afterwards that they hear about, and then, oh, do I need a touch up, or what happens with that? And with Smile, we can very easily say, well, there is proven less dryness. Study after study shows that, and then just subjectively, patients definitely, even right after the procedure, they're much more comfortable. Even with LASIK, they're only uncomfortable really for one day, but for certain patients who, if they move during Smile and they end up getting LASIK, they have one eye with LASIK, one eye with Smile, and they definitely say that is an advantage to the Smile eye. It feels more comfortable faster. And then in terms of the touch-up enhancement, there's not really that much for LASIK, but as we see on the slide here, there's less for Smile, and that makes patients feel a lot more comfortable. So I do like to make sure that they are comfortable with LASIK, because LASIK is a great procedure, and if they do happen to move, that's our kind of backup plan, and I don't want them to be disappointed with having LASIK. And it is great. And then also just staff, about half of our office staff has had Smile on themselves, and the other half is a LASIK. So that's always a nice thing to tell patients, because it is something that we are really excited to kind of bring them over to the other side, like, come join us, be free of your glasses, and that's really nice for them. So that's kind of how we present it, just the small advantage.
What about if each of you could answer what percentage of your laser vision correction is Smile, LASIK, PRK? Ro, if we could start with you.
So I dive into stuff, and I really enjoy doing Smile. You know, LASIK is, you know, I would say a simpler procedure than what I normally do with like cataract surgery and the other procedures I do in the office. I really enjoy doing a Smile case, and the patients love it. So we're about 90% of our cases now are Smile. You know, you can't do hyperopia, and there's some other cases that you can't do, but I love the procedure. I love doing the procedure. It feels more surgical to me than LASIK did. And then the patients are just so happy that they can go back to their normal life. So when I get in discussions with patients about smile, that's the one thing that, and we tried everything. We tried a lot of different ways of talking to patients about this. And it really comes back to the next day they can do whatever they want to do. And then as a surgeon, much more comfortable at night knowing that there's really nothing they can do to mess up the surgery that we did for them. So we have a lot of patients that fly in from different places. So I had a patient from Brazil and Argentina come together. There were a couple. We did their surgery, saw them the next day, and they could fly out. I didn't have to worry about them getting on a plane, their flap drying out, or them rubbing a flap in that post-op period. So now we've had patients that have flown in from California, Florida, South America, like I was saying before, and instead of telling them they'd have to stay in our area for a week, they basically have come, had their surgery, and within a couple of days they've gone, and we've set something up with a local doctor there. And I feel very comfortable doing that because I know they don't have a flap.
Yeah, so you said again, those people are all coming from California, is that right?
No, I've had patients from different parts. So, I'm
Like all over California? Like, or
not LA, not LA. Northern California. I grew up in Northern California, so I have a lot of friends. But again, I think the reason they're coming, because there's surgeons everywhere, is that we're offering the newest and latest technology in terms of refractive surgery, and they want that. I think if you tell somebody with all the technological advances that we had that they're going to have the same surgery that their friend or relative had 13 years ago, they would kind of look at you and go, so hasn't things improved over time? There's nothing better. And now I have that answer for them. I said, this is the next step. And I fully believe that this is the future of LASIK, and that's how we refractive correction.
I want to just jump in on something Rose said, which I want to just echo and reinforce. As a surgeon, it feels so good doing this procedure. I mean, we all can do. We've all done many LASIK, and it's an amazing procedure. But you just feel the minimum invasiveness of it it's just so much more like rewarding when you do the procedure. The precision is clearly better. That 1/3 enhancement rate. I can't believe the outcomes at the high end, how precise they are. And it really is, as Rose said, it's that next generation thing that your patients come in and have somebody that was done 10 years ago, and this one is just better.
Gotcha. Hey, Rex, what percentage of your cases are smile versus excimer at this point?
Yeah, I mean, it's at least 90%. I mean, the only time that I'm not doing a smile is when we've got too much cylinder, with the rule 250 to 275, with a nomogram adjustment, because 3 is the highest we can program. And then the hyperopic patients, and then, maybe if we have somebody that's minus 0.75 or something like that on the very low end, I'll do a LASIK on it, -1. But I mean, everybody else who qualifies, I mean, is a smile automatically for me.
Gotcha. And Erica, you're in a large group IQ laser in the LA and San Jose area. How many surgeons do you have doing smile? And if you compare yourself and Robert and so forth, what percentage of your cases are smile versus excimer, and maybe the other doctors in your practice? How's it changed over the last, let's say, 12 months?
Yeah, so there's 3 of us, and we all started doing smile pretty early. Dr. Fan in NorCal, he started doing right when it was approved, and then Dr. Lynn shortly after that. And I started when I started, smile that was 2 years ago. Smile was still not, like, nobody knew what it was yet. So we had to kind of be convincing people about it, and they didn't know what it was. And there's definitely been a huge shift that I'm sure everybody on this panel has seen, where now people are coming in and asking them for a smile. Their friend had smile, or that's the only thing they want. And now the same as the others, about there's still a few patients who are a little bit off put by they like that their friend had LASIK and they want to have LASIK, but that's very few. Now most people want SMILE. So about 90, 95%. And we're the same across the board. So
Yeah.
I mean, when you can tell the patient that it's been around for 10 years outside the US and over 3 million procedures have been done,
right.
It's really helpful. Because you're right, Erica, there are definitely those that want to default back to what their friend who referred them had. But then when you talk about the issues with the dry eye and no flap, they understand. And having that 3 million number, I think, really puts things to rest about concern.
Yeah, I think it's a good point.
What's interesting to show how much SMILE is adopted by patients is that it's actually more expensive to have SMILE in our clinic than LASIK. So it's actually, if you think about it, if patients wanted a cheaper refractive procedure, they could have the LASIK procedure, but when we explain to them what they're getting with a SMILE procedure, they're going for the upcharge and the more expensive procedure.
Gotcha. Yeah, I'm kind of like Ro. I mean, the second I believe in something, I don't put my toes in the water. I do a cannonball. I'm like all over it. So we're 95% SMILE. I do essentially zero hyperopic LASIK because I end up doing IOLs on those patients. So like you, we're kind of all in, and I think it's a very easy sell for us in the sense that I had my first patient about 2 weeks ago that wanted to do LASIK versus SMILE. He actually was doing military, and I think he just read all the military information on LASIK. And I wanted to tell him, I said, SMILE's approved by the military, but I just sensed I wasn't going to be able to convince him. So that's the first non-conversion to SMILE we had in 2020. So we've probably had, now looking, maybe one person per year that we don't convert for, and they will say something like, Eric, I've had 10 family members that had LASIK and so forth. So, okay, well, we'll move on to the next slide. And this is really kind of, we were talking about the enhancement rate list. So this was about 18 months ago. I was in Berlin and doing a talk at the Zeiss European Laser Users Symposium. And I knew what our enhancement rate for LASIK versus SMILE was. We were enhancing about 1/3 the number for SMILE versus LASIK. And Detlef Breyer from Dusseldorf, Germany was up talking, and he said, somehow just on the fly, he said, yeah, our enhancement rate for SMILE is 1/3 of what we have with LASIK. I kind of stared up at the wall and go, oh my goodness, I can't believe that. We found the same thing. So I went out in the hallway, grabbed Dan Reinstein, didn't tell Dan anything that I knew or what Detlef had just said. And he said, oh yeah, it's 1/3 of what we have with LASIK. So then I grabbed Sri Ganesh, Sri's on the right hand of the slide, and asked Sri the same thing. Oh, it's 1/3. I said, wow, so I think we've got something here. And then about 6 months ago, or I guess now it would have been February of 2020, I was skiing at the ACOS meeting in Aspen, and Dean Corbett and I were on the same lift, and Dean had picked up SMILE about 4 years ago. And I said, Dean, what's your enhancement rate SMILE versus LASIK? And without me saying anything, 1/3. And so there's something there. Is it the fact that we're doing the surgery in a vacuum with the patient interface? We don't have to worry about the environment, specifically from the end of the optical train to the corneal surface, humidity, particulate matter, barometric pressure, so forth. So there is something there, and maybe we could talk about that. Rex, if you want to kind of give some of your insights on that, that would be great.
Oh, it's incredible. I mean, I'm using SurgiVision. They have the nomogram now on there for SMILE, and you can print out your attempted versus achieved, and the R square is like 0.99. I mean, it's incredible, way out at the high end. And I almost feel like at this point, when we're off, maybe it was a refraction issue. Maybe we just slightly missed on the refraction. I mean, that's really where we are at this point, because the precision, low end, high end cylinder is clearly another level. I love the fact you can program to the 100th of diopter. It's just the precision is clearly better.
Gotcha. Ro, if you want to comment on that, what you've experienced as far as enhancements.
Yeah, we didn't really have a lot of enhancements on the LASIK side. We've been doing this, and I've had the same group with me on the LASIK side for a long time. I think the main thing for me is the dry eye aspect of it. You know, we have a huge dry eye clinic. Patients come to me to get their dry eye taken care of, and then they want a refractive procedure. And we've always like turned to PRK as, so that we wouldn't make a flap and cut nerves. So to me, the biggest sell on our end is that Smile has taken up that PRK for the dry eye patient, because we're just not seeing the dry post Smile dry eye. Enhancement wise, we had an extremely low enhancement rate anyway. I wouldn't say we would, you know, it's less than 0.001% anyway. So, but I'm impressed with Smile in that way too. If it was higher, then I would be less impressed with it, but it's definitely lower or to the same, but mainly the dry eye thing is the biggest.
Great. Erica, what has your group found? Have you, with all the years experience with the three docs, have you seen a difference in enhancement rates, or at least can you tell?
Yeah, I would say it's similar to the third. And our patient population just has pretty high prescriptions. So they're at kind of higher risk in general of needing enhancements. And we have found kind of this similar pattern as you have all found, as you mentioned already, about 1/3. And also the other thing that seems to have come out of a lot of research in China with the patients with the higher prescriptions, that it does tend to be more stable over time. So again, is that because it's biomechanically more stable, or the epi remodeling changes because there's no flap? I think there's a lot of research, no real conclusions done. And then also, as you mentioned, that closed system where the humidity and dehydration doesn't really play into the treatment. So yeah, I would agree with everything that you've said, and of course the dryness as well.
Sure. We're going to pass it over to Rex, and Rex is going to talk about post-operative visual acuities. And the reason we need to talk about this is early on with, we're going to call the Smile procedure, relux procedure. The early relux procedures were actually creating a flap and then peeling the lenticule off the bed. Once we went to the small incision, we had very high energies, and I know Rex is going to talk about this, but the recovery, there's no doubt that the recovery, let's say 5 years ago with Smile, was slower than what we see with excimer laser. And at present, now that we have the energy changes that Rex will talk about, you know, it took, I would say with Smile, you know, it's been under investigation for almost 20 years. It's been clinically practiced for almost 10 years. It's really become optimized, let's say in the last 3 years. It now has changed what the post-operative impression is. When I first started doing courses in the US, we kind of had to talk about this, and we gave comparisons of the old gene energy settings in the FDA trial and what was transpiring. We were getting close, but not quite there. And I think Rex can now share what we know with the latest iterations of software, both outside the US and inside the US, what that recovery time looks like for a typical Smile versus excimer laser patient. Rex, if you want to take over.
Great, John. So yeah, did the first cases on the West Coast March of 2017. And this is when we had sphere only, no astigmatism treatment. And we also were limited in terms of how we could adjust the energies. So, you know, the two parameters are the spot energy and the spot spacing. And we were locked into a relatively tight spot spacing of 3 microns, while the rest of the world could actually go out to 4.5, which is a 50% increase. Well, that translates into a lot more energy deposition into the cornea. That translates into slower vision recovery because we have edema, the tissues have to settle. And so I said to myself, when we got the new energies with the astigmatism approval, what happens on the visions on day 1 and month 1 with low energy versus the higher energies we had before? So this is a paper that's available ahead of publication, JCRS. It's going to be published officially January 2021. And it's a cohort of low energy Smile, high energy Smile, which is the original from 2017, and wayfront optimized LASIK, all done by me. and just looking at the numbers, and this is post-op day 1, uncorrected acuities. And the first point is look at the high energy. I mean, very low numbers, 37%, 20/20 or better. And that was an issue because you've got a LASIK surgeon who's used to 90+% on day 1, 20/20 vision, and thinking about adopting a new procedure that maybe they have to purchase a laser, maybe they have to learn, and of course they have to learn a new procedure. Doesn't really make a lot of sense. But now we are equivalent to LASIK on postoperative day 1 with the uncorrected acuities. And so that's really a game changer, because you have that and you roll in all the other things we talked about, the dry eye issues, the no flap, the appeal of no restrictions after surgery. And so really, to me, there is no other reason to be thinking about doing LASIK in patients that qualify for both SMILE and LASIK. If we go to the next slide, you'll see that on post-op.
Rich, can I ask you a question?
Yeah.
Is this eyes or patients?
I'm sorry?
Is this eyes or patients?
This is eyes. This is monocular.
Yes, I
Yeah.
think that's a good point for the audience to understand that this is eyes and not patients. I mean, this is head-to-head. How are you doing? You don't have to worry about summation that might be polluting.
Yeah, we matched spherical equivalent corrections on everything, and so we wanted to try and make this as apples to apples as possible.
Gotcha.
So if you go to the next slide, it'll show post-op month 1, and you see 95% both with the LASIK and the low energy. I mean, you look at the high energy, it was still lagging even at 1 month, and so it's just a better procedure now with the lower energies. On day 1, you see very little edema, and just the vision recovery is essentially the same, and so it's a compelling change.
Gotcha. That's interesting. So you talk about spot separation and then the energy per spot. And our calculation was that the high energy versus low energy, the energy difference was about 35%. So when you're doing low energy, you put in about 35% less total energy for any given treatment. And again, all of these treatments are going to essentially have the same energy because it's the same number of spots almost regardless of refractive error.
Yeah, right. It's not like an excimer ablation where you're stacking up more and more shots for the higher treatments. It's exactly the same number of shots, per patient or per eye, regardless of the correction. So we clearly want to minimize, because any tiny amount of OBL or anything like that can affect the next shot, can affect the edema that you have to deal with, can affect how easy it is to dissect the tissue. So controlling for OBL by minimizing energies is much, much more important here with SMILE than it is on a LASIK flap, for example.
Sure. And I think if you took this slide out and be interested, I presume you probably don't have this in your paper, but if you did, if you looked at 3-month data, a high energy SMILE would probably get very close, or it's getting closer to the LASIK. And it's that amount of trauma. It takes that certain amount of time for that to resolve.
Well, what was dramatic too, John, because you started very early in the process, was the vision was down. Not only the uncorrected vision, but the best corrected vision was down as well, and because of backscatter. So which was a little worrisome. And when we first started, that you've got on week 1 you've got like 20, 25, 20, 30 best corrected vision. That's completely gone now with the low energies. So it's a dramatic difference.
So we talked about enhancement rates earlier. So let's say you get to the point that you do have to enhance. I think a couple of things come up. When do you enhance? Do you enhance at 3 months like a lot of us do for LASIK? Do you wait a little bit longer? What procedure do you enhance, and what are you having to enhance? Eric, if you want to kind of take a stab at that, and we'll go down the line.
Sure, yeah. So we haven't had a lot of enhancements, which is nice. But in terms of what I would choose, so there's a few that officially recommended by Zeiss is PRK. And then there are people talking about doing a very thin flap over the 120 cap and just doing LASIK on top, or converting the cap into a flap, which would be a 120 flap. So depending on the patient and what they were pre-op, that's kind of how I decide what to do. I've only done PRK and the kind of pseudo circle, or however you want to call it, which is converting the cap into a flap. So if they had a smaller prescription to begin with, they have a lot of tissue left over, then I'll just do the circle procedure, and that's been working out. The end result is similar, very good for both, and then just to save them from having to recover from PRK. But if they had a really high prescription or they don't really have much tissue left, then I'll go with the PRK.
Gotcha. Rex, what are you finding out you have to enhance? What visual acuity or what complaint might push you to do an enhancement in a SMILE patient?
You know, the enhancements that I did, very few, maybe 3 or 4, were really early on in higher corrections, and it was essentially an undercorrection on the nomogram is kind of the way I kind of looked at it. And I did PRK on those patients. Cutting a flap is certainly a possibility and works well. But it's sort of, for me, it goes against a lot of why I did SMILE in the first place, especially in a high correction. You know, I don't really want to compromise the biomechanics in that patient. So I've been doing PRK on those patients. And I talked to, as I mentioned, I use that flip book. So I've presented all 3 procedures to the patient in advance and told them how amazing these procedures are. You know, 30 years experience with PRK. It's a tried and true, and the end results are great. And so, you know, a little bit longer recovery time. So PRK is the way I've gone with mine.
Gotcha.
Ro hasn't done any, I'm sure.
Well,
you know what? That's so funny that you say that. We haven't done an enhancement yet. So I've got 2 patients that we're considering enhancements. And it's funny because their vision is still improving. And when I ask him, well, you know, it's been 6 months now. Do you think you need this eye touched up? And they're still thinking about it. And, you know, we've done a contact lens trial with them, and I'm going to do a surface ablation on them. Again, from what was said before, the reason why I've convinced them on SMILE is that I feel it's better than a flap. So I do not want to create a flap, and I don't want to create a dry eye situation. So I will do surface, but what I've noticed is that these patients are continuing to improve as time goes on. And I'll talk about that in my pearls. You guys were talking about trauma. I think what you'll find as you get more and more experience in SMILE, what you're trying to do is create the least amount of trauma when taking out the lenticule, because that will affect how quickly they'll get to 20/20. So one thing in Rex's study may be that he's also improving. I'm sure the energy levels have something to do with it, but it's kind of like cataract surgery. I think as you get more and more experience, you create less and less trauma in your technique to get the lenticule out.
Yeah, no question about that. And, you know, it can be frustrating starting out if you're learning a new procedure and you have OBL issues. You know, this is a new procedure to learn. So it just underscores the point. You want to work with your application specialist when you're starting out with a new laser and a new procedure, and make sure that you optimize, control the temperature in the room and those kinds of things. It's important.
Great. Thank you all very much on that. So our next slide is some data that we worked on in Kansas City, looking at really satisfaction of the patient. So you can look at the post-operative refractive rates, and we've already talked about they're very good. And we have 2 VisuMax lasers, so 2 centers, and there's 2 ODs, 2 separate ODs that work at each of those clinics. And we looked at the patient satisfaction at 2 weeks, 3 months, and a year. And it's really simple. So we get the patient at 2 weeks, you know, how happy are you with your right eye? You know, it's from 1 to 10. And how happy are you with your left eye? And then how happy are you with both eyes combined? So if you look at this first on the Kansas side, you already have an average over 9, which I think is pretty darn good. If you go at 3 weeks, 9.13, 3 months, 9.54, and 9.72. So improve at each interval that the patient's happy, and combined number is higher. Now you get out to 12 months, and it's obvious it's very good. And these are large numbers of patients. There's 144 eyes or 72 patients in the Kansas side. The Missouri side's a little bit lower number, but again, once you get out to the 3 and 12 months, it's basically the same number. And if we look at the astigmatic corrections, Rex was talking about how precise the spherical corrections are. The astigmatic corrections, I would agree, just seem to be spot on. Again, we're looking at roughly 9, and then once we get out to 12 months, we're nearly 10 in both groups. It doesn't matter if it's Missouri or Kansas side. When you're getting over 9.5, when you're getting over 9.75, I mean, that satisfaction is very high. That's interesting. We'll have some patients that'll, I get these reports every day, patients 2 weeks out, this is where their correction was before, this is where they are now. And it'll be like the person's, plano sphere, they were a -9 and they're giving us a 9 rating. I'm like, what the heck is with that? So if they're not giving us a 10, I have the optom dig in. And sometimes it'll be the person will say, I'm an engineer, I don't give a rating of 10 for anything. And so you're like, you want to put your hands up in the sky and scream, but they rate us really, really hard. So you might have somebody that's literally 20/20 -1 in one eye and 20/20 in the other, and they'll give you an 8 in the 20/20 minus eye, and they'll give you a 9 in the 20/20 eye. And you're like going, I have just got rid of, 6 diopters of myopia and 2.5 diopters of astigmatism. You got to be kidding. So they judge us really hard, and even with that, we get fantastic numbers. Rex, were you going to say something?
Yeah. No, this is just such great data, and boy, a lot of work goes into getting data like this. I'm curious, how far back? Obviously, the spherical smile. Probably some of those eyes are older, like from way back. I'll bet you if you looked at your recent cohorts, the increase, it would be more stable from the beginning. In other words, higher numbers at the beginning than out at 12 months. Because you like an 8.8, I mean, that patient probably was one of these that, had OBL, higher energies, and now I bet you if you looked at the cohort from the last 6 months, it would be even more impressive in terms of the early numbers.
Sure, probably so. First up, so my top pearls are the following. We hit this a little bit earlier, and I think Rex or Roe had said, that LASIK is pretty easy. Cataract surgery is a little bit more difficult, and I've taken the stance that when you start doing smile, you have to be more facile in the sense that you're doing surgery within a pocket, and so you have to be comfortable with that. And a lot of it ends up becoming maybe inherent, that it's visual, but you lack a lot of the visual clues that you might have if you were doing open air surgery. So you learn some things, and you have to have certain wrist movements. So it's going to be new. It's going to be something that you're going to have to kind of get over some curves or learning curves. And I may have you all kind of talk about your learning curves in just a second on that. I think watching numerous narrated surgeon videos is really helpful for anybody that's considering doing smile. And then I think it's important to talk to colleagues that have migrated to smile and find out what has worked for them and maybe what hasn't worked out for them. So again, it can make your life easier. And I think it's very important, because I work closely with them, the clinical application specialists with Zeiss are wonderful. They've followed so many doctors through this process. If you can kind of bend their ear and have them help you walk through that process, I think it's very helpful and just minimizes pain associated. Okay, Erica, these are your pearls. Fire away.
So starting again, number 1 with patients, and this was just again, since I was starting out at the same time that I was learning smile, and my clinical application specialist, she was really hard on like, hey, just take your time and it's fine. And then I think that really identifying the planes is something that is pretty unique to smile. And if you don't do it, you can really get yourself in trouble in the beginning. And then if you do, it's really easy. So just to really take time with that. My first eye, I did not stabilize the eye. And that's because a lot of the videos that I watched, people weren't really stabilizing the eye. And I was so focused on what I was doing in the eye that I wasn't really focused on the patient. The patient was really a good patient until he wasn't. And and he
I love
belled,
that.
and yeah, and then he ended up being fine, but it could have been not fine. And then so after that patient, I always stabilize the eye, and it also makes it easier to dissect. And then number three, this is what Zeiss recommends. Start with easy, nice, thick, juicy lenticules. Patients who have probably worn contacts or hard contacts for a long time, so they just don't have reflexes as much as people who have never worn anything. And then I think average everything is a good place to start with the first few cases. And as Rex has published, thicker corneas with more OBL, maybe try to avoid that to avoid difficulty dissecting or finding the planes. Leave yourself some counter traction, and that's something that the Zeiss representatives will kind of go over as well. And that's the same thing. You want to be able to dissect and not have the lenticule all kind of squish onto itself and not able to get it out. During posterior dissection, especially with the thinner lenticules, to make sure you're pushing down and not up and inadvertently causing a tear in the lenticule. And afterwards, this is really important in our practice just because we do have a lot of those high myopes, to smooth the surface with a WEC afterwards to make sure there's not any redundant folds where there shouldn't be. And number 7, checking the cylinder sign. This is for LASIK too, so but the cylinder sign is not super obvious, and it's very easy to put in the wrong cylinder sign. So making sure that you're double checking, triple checking with the text, and not treating the wrong still. And I think Rex is going to go into this too, but reference the Purkinje image. So because the smile is a treatment, we want to make sure that it's centered with their visual axis and not the pupil. And I think there's lots of different ways that you can do this. A printout of IOL Master or the Magellan or whatever. A lot of our diagnostic machines have a Purkinje image, and then just kind of putting it up there and knowing exactly where to center the treatment. So.
Great, thank you so much. I think Rex, fire away.
Right. So the first one we've talked about a lot, and bringing in, patients that have been sitting on the sidelines because they're fearful. I think that's the number one reason that prospective patients don't come and seek out refractive surgery. So we've addressed that. I love the flip book, as we talked about. Energy optimization, super important. This comes back to the clinical application specialist. Every laser is different, and so when you're first starting out, you really want to work with an application specialist to bring those energies down so that you've got the minimal amount of OBL, but you can still dissect, and we don't have, black spots that might represent uncut tissue. The lower the energies you can use, the better you're going to have on post-op day 1, for sure. And then the reference image that Erica was talking about, very, very important, especially for LASIK surgeons that use femtosecond laser to cut the flap. Yeah, we center the flap, but it can be a little bit off, and as long as you have enough space for the ablation, it doesn't matter because that's not the treatment. But it's important to realize this is the treatment, and so we want to center on the visual axis. I use the Galilei system. It has a reference picture which shows the pupil and the visual axis with a crosshair through it. And so I print that out and bring that in, tape it upside down on the laser so that I can see where that visual axis is relative to the pupil, so that when I go and look through the oculars, I know, can confirm that when I dock, I'm in the right place. The nice thing about the VisuMax, it has a curved applanation. So there's a bit of auto centering that happens as long as the patient's looking at the light. You're usually good to go, but it's always important to have that reference point there. And then the starting nomogram, we haven't talked a whole lot about nomograms here, and would love to hear the other panelists, what they're doing. I'm up around 8 to 10% that I'm adding on the sphere. I think that it's pretty much across the board. We've seen that. I had 15% on my with the rule cylinder and 0 on the against the rule. And so just like John was saying, I would like to have a little bit more cylinder. range, because on with the rule, you got to add 15%. You know, a -3, you need to program a little bit more than -3. So, yeah, so there you go.
Great. Thank you so much, Rex, on that.
So Rex, a question for you. Does it matter the amount of sphere in terms of your 8 to 10% correction?
No, it's 8 to 10% across the board.
You do it like
so
I
a
did,
-2, you treat the same as a
sorry?
-6. A -2, you would treat the same as a -6 in terms of adding the
Right. So
10%.
for, let's say it's 10%. So for -2, it'd be -2.2. For -8, it'd be -8.8.
Yeah, I do the same thing as you, Rex. I do the spherical adjustment based upon the minus cylinder sphere. So really,
Eric, what are you guys doing?
yeah. And so row that would be, -2 gets to be a -2.2. A -6 is a -6.6. Are these your slides, Rex?
Yeah, these are some just the most recent eyes that are at least 3 months out from my SurgiVision nomogram. And actually, I just looked today at my most recent 30, and my 2016 number is now like 80% and 100% on 2020 at least 3 months. So the outcomes are just spectacular. Go to the next slide. And here we're talking about that predictability and the accuracy, 100% within a half diopter of the target. And you can see the attempted versus achieved out there. You see the R-squared is 0.98. I'm now up to 0.99 because I have more eyes now. But even at the high end, I mean, it's not spreading out. It was a lot of the older excimer lasers. You start getting them to the high end, you're getting more scatter because of just differential dehydration and all that. We don't see that here at all.
Yeah, again, that kind of goes back to its SMILE being dose independent versus LASIK is somewhat dose dependent. Yes, R-squared at 0.98, 0.99, phenomenal. How about here?
Stability, this is out to a year. I mean, there's this rock solid. And cylinder, 97% with less than a half diopter, which I think is pretty remarkable because we can't program a half diopter right now. And I don't know if we want to talk about that at all, but the cylinder corrections are just spectacular.
Yeah, good point. Ro, here's your pearls. Fire away.
Yeah, so it sounds like I'm the new kid on the block because this is going to be I'm going into completing my first year, so I'm probably closer to the starting out doctor. So I really think that you can't wing it. I mean, I don't care if you have 20 years experience doing LASIK, 20 years of cataract, whatever your experience level is, you're going to have to start over. It's a new procedure and have a game plan. So talk to surgeons, watch surgery, pick a plan that you're going to use and go in there and start to do the procedure. And then you'll get that feel. If you're an experienced surgeon, that feel will come pretty quickly. And then you'll start tweaking it, saying, okay, well, how do I create less trauma in the eye? And I really do think that's important. I think the less manipulation, it's almost like cataract surgery in that way. The simpler you can make it and the easier you can make getting the extraction of the lenticule, the quicker they'll get to 20/20 and see the way that you want them to see. Any new procedure that we bring into the clinic, you got to get excited about it and you got to get your staff excited about it. If not, if your staff isn't on board, then it's going to fail. And that's what I've seen time and time again, bringing in new technology and new procedures, that you have to not only educate yourself, you're going to have to educate the whole staff and then educate everybody from the front desk person all the way. That's the best way to get these things implemented. And then start working on the message that works for your group of patients. And this message is different from, I talk to several doctors and I say, this is the message that I give my patients and it seems to work. We tried a whole bunch of different messages to patients, and the message that worked for us is basically get back to normal activity right after surgery. Flapless LASIK, they understood what LASIK was, and now we're just incorporating flapless. they really didn't understand what the word smile was. And that is a little bit a higher order in terms of getting them to come in, listen to all the things that you have to tell them, and then telling them this is smile. But I think that's going to change. You know, Rex said it's like 10%. When this gets to 40, 50, 60%, people will start knowing exactly what smile is right away. And then it depends on your area. So we don't have, in Memphis, there's nobody doing smile except us. And then in Nashville, there's myself and another doctor doing a smile, and that's it. So really not completely adopted in our area. And that goes for Mississippi, Arkansas, and the surrounding areas. And then I really get into explaining to patients what's going to happen. And John alluded to this. Tell them about the losing of the light, not to move, all those things. I've seen surgeons that put their hands on the patient's head, and I found explaining to them step by step what's going to happen to them before they get in there. You don't have to do that. And we do a countdown with them. So explain exactly all of those things before you get in. It'll make it much easier for you to do the procedure. I don't use a stabilizing forceps. And I find that talking to the patients beforehand and during allows me to do that. I don't have to put my hands on them. I don't have to use a stabilizing forceps. And then explain to them what their vision is going to be afterwards. I tell them, look, we've made a pocket. There's going to be fluid in that pocket. As the fluid evaporates, your vision is going to get sharper and sharper. And we've seen it. You can mitigate a lot of phone calls and patients worried about their vision just by explaining to them what to expect afterwards.
Hey, John, I got one more pearl.
All right.
Give your patients one of these masks.
Oh, there you go.
With your logo.
Very nice. Very nice. So, one thing I was going to say, Rolando, I think you got it dead on. When I'm, consenting a LASIK patient, it's really, hey, I'm swinging for the fences. You're going to do great. For the smile patient, there's that critical step of getting the refractive cut. So I spend some extra time with them to stay focused on the green light, avoid that really hard blink, and I describe what a Bell's phenomenon is. And I go over that with them. I probably spend an extra 30 seconds, maybe an extra 45 seconds that I don't do with the PRK or LASIK patient. I think it really helps avoiding any aborted procedures, at least in my experience. So let's go through a summary. Again, very high patient satisfaction, and I think surgeon satisfaction with the procedure. Again, patients do talk, and we do have word of mouth, and we share that and try to exploit that as much as we can. And I think we've all learned that the smile is less invasive. There's greater biomechanical stability. There's less dry eye, and there's just less worry post-op. Again, there's no flaps, so you don't have to go through all these things that we've historically done, talking about avoiding rubbing the eye, avoiding makeup, and so forth. For us, it's been really much easier, and it's gotten better even post-COVID of how we manage our one-day patients. In fact, we are not seeing one-day patients in-house any longer. We do them all by telemedicine. It just made life easier for everybody across the board. Obviously, if somebody has to be seen, we will see them, but other than that, we don't. But we'll see them back at 2 weeks. And then again, decreased enhancements just makes our life easier and makes a more successful experience for all patients included.